All right, let's jump right in. We're going to tackle something you'll see on literally every rotation: what to do with an abnormal white blood cell count.
You know the feeling, right? You're pre-rounding, the overnight labs finally drop, and bam, there it is, a critically high or low white count. And for a second, your heart just sinks. You're thinking, oh no, is this something really bad?
Okay, but here's the thing you absolutely have to remember right from the jump. Yes, you have to pay attention to that flagged lab. But so many of these abnormal counts, both high and low, are caused by things that are totally benign. The trick is having a game plan, a framework, to figure out which is which.
So here's our plan. We'll start with a basic framework for any weird white count. Then we'll dig into leukopenia, the low counts, and really focus in on neutropenia. After that, we'll flip over to leukocytosis, the high counts, and at the end, we'll pull it all together with the key takeaways you can actually use.
So, where do you even begin? Well, for any abnormal count, you start with the basics. It's all about a systematic evaluation. That means getting a really good history, doing a thorough physical, and actually looking at that peripheral blood smear. It's the foundation that's going to keep you on track.
Okay, let's dive into our first big category then. We're talking about leukopenia. That's just the fancy term for when the total white count is lower than it should be.
So, what does that really mean? It's pretty simple. A decreased total white count. But here's the key. That drop is almost always being driven by one of two specific cell types, your neutrophils or your lymphocytes.
And figuring out which one is low is absolutely critical for your differential. So for neutropenia, we're talking about an absolute neutrophil count, the ANC, of less than 1,500. For lymphopenia, it's an absolute lymphocyte count, or ALC, below 1,000. This is like your first major fork in the road.
Now, you can see either of these for sure, but for now, we're really going to hone in on neutropenia. Why? Because it's way more common, and honestly, it's often the one that's more clinically urgent.
And when you look at the causes, this is what's so fascinating. Look at the sheer range of things that have nothing to do with malignancy. We've got inherited stuff, infections like sepsis or HIV, tons of common medications, even nutritional problems like B12 deficiency, and autoimmune diseases. It's a massive list. Let's zoom in on one of those inherited causes because it's a great example. It's called Duffy Null-Associated Neutrophil Count, or DANK. This is a perfect example of a totally benign finding. You'll see it a lot in people of sub-Saharan African or Middle Eastern descent, and it just means they have a chronically low ANC. But, and this is the part you have to remember, it doesn't cause any problems. No increased infections, nothing. If you can spot this, you can save your patient from a massive and totally unnecessary workup.
Okay, another huge one you'll see all the time is medication-induced neutropenia. There's a classic pattern to look for. It almost always kicks in within the first 3 months of starting a new medication. The patient might have a fever or some painful mouth sores. And the best part? The fix is easy. You just stop the offending drug, and they typically bounce back in about 1 to 3 weeks.
All right, enough about low counts. Let's flip the coin and talk about the opposite problem: leukocytosis. This is when the white blood cell count is too high. And the logic is pretty much the same as with leukopenia. It's an increased total count, but it's usually being driven by a spike in one of two cell lines: either neutrophils, which we call neutrophilia, or lymphocytes, which we call lymphocytosis.
So when you see a high neutrophil count, what should be on your mind? Well, this list probably isn't going to surprise you. We're talking about the usual suspects: bacterial infections, any kind of inflammation, common meds like glucocorticoids, and even things like physical or emotional stress, smoking, and obesity. These are really the bread and butter causes of neutrophilia.
And speaking of smoking, here's a fantastic clinical pearl you've got to remember. It's not just a common cause of a chronically high neutrophil count. The wild part is that the neutrophilia can stick around for a year or more even after the person quits smoking. It's such a crucial piece of social history that can explain a lab value that just won't go away.
But what about the other cell types? Let's talk about monocytes for a second. A high monocyte count can just be reactive, sure. But here's a major red flag you need to watch for. If that monocytosis is persistent, we're talking longer than 6 months, and you see it alongside anemia or low platelets, that's a different story. That patient needs a referral to hematology, period.
Okay, that was a lot. So let's bring it all home. We're going to boil this down to the absolute key takeaways, the stuff you can actually remember and use on the wards.
First up, don't forget dance. See a chronically low neutrophil count in a patient of sub-Saharan African or Middle Eastern descent, your first thought should be this benign condition. Spotting it is a huge win for your patient.
Number 2. Always check the med list for neutropenia. Be a detective. Look for any new drugs started in the last 3 months. And remember the classic pattern. Stop the drug, and the count should come back up in 1 to 3 weeks. It's a dead giveaway.
And finally, number 3, ask about smoking. It's such a common reason for a chronically high neutrophil count. And remember that wild fact that it can last for more than a year after they quit? It's a simple question that can solve the whole puzzle, but you have to remember to ask.
So there you have it. Now you've got a framework. The next time that lab alert goes off, you're not going to panic. You're going to have a plan. So the only question left is, which one of these benign causes are you going to spot first?